Good afternoon. I am Dr. Sanjay Dasgupta, Professor Nephrology, IPGMA and SSKM Hospital. Today my topic is pedal edema and chronic kidney disease. Now first we must know what is edema. Edema is a condition where extra fluid accumulates in the body around the organs and tissues. Now if a person is most of the time upright, then it accumulates in the legs. That is known as pedal edema. But if the patient is recumbent, that is in lying down position, it may appear in the back, known as sacral edema. Sometimes edema not only means accumulation of fluid in the legs, but it also accumulates in the body cavities, like around lung, pleural space, known as pleural effusion, in the abdomen, known as ascites. Now, what is the mechanism of edema? Mechanism of edema, it may occur in two ways. One, there may be excess of fluid in the body. That means too much fluid. Number two, there is too less protein. If there is too much less protein in our blood vessel, then there is something called oncotic pressure that diminishes and fluid goes out. So either there is too much fluid or there is normal fluid but less protein so that it cannot retain fluid. And also number three, there may be blockage in a lymphatic system, lymphatic blockage that may also cause edema. Now we must know what are the causes of edema. If any adult patients come to our chamber with edema, we must first ask him whether he is taking any antihypertensive drugs or not, like amlodipine is a common cause of edema. Number two, if the patient is hypothyroid or not, whether he is taking thyroid drugs or not, or then we have to check for thyroid blood tests, whether he is hypothyroid or not. Then heart failure is a common cause of edema. Renal causes, that is kidney causes, that is also a common cause of edema. It may be chronic kidney disease, it may be acute kidney injury and nephrotic and nephritic syndrome. If the patient is having lung disorder, which secondarily affects the heart, known as cor pulmonale, it may also cause edema. The patient may also suffer from chronic liver disease. That may also cause edema. So it has got a lot of causes, starting from medicine like amlodipine, hypothyroid, which are benign causes, and others. The patient may have heart failure, renal causes, liver causes, etc. Sometimes, as earlier I have said, sometimes there is lymphatic obstruction, like a patient may have underwent surgery for breast carcinoma, then one hand may be swollen. This is lymphatic obstruction. There may be filariasis. This is lymphatic obstruction. Sometimes history taking helps in ascertaining the cause of edema. If the patient is having dyspnea or shortness of breath, it may be due to heart and kidney causes, and also sometimes lung causes that may secondarily affect the heart. If the patient is having jaundice and disproportionate ascites, that is abdominal swelling, patient may have chronic liver disease. Edema can sometimes be localized in one leg, one lower limb. That is cellulitis. Cellulitis means infection in one particular leg. So that may cause edema in a single leg. If the patient is having lymphatic block, just now I have mentioned, it may cause a swelling in the unilateral leg, one leg. If the patient is having fracture, he may have swelling in one leg. If the patient is having clot in blood veins, that is known as deep vein thrombosis. So that may cause localized edema in a single leg. Edema can be pitting and non-pitting. What is pitting edema? If we give a pressure on the legs just above the medial malleolus, it will dip. That is known as pitting edema. Most of the edema are pitting. However, some edema are non-pitting. That means however hard you press, it will not dip. Like hypothyroidism, like lymphatic obstruction, which is the non-pitting edema. Now, apart from taking a history, what is the drug history, what is the thyroid history, whether the patient is having jaundice, whether the patient is having shortness of breath, decreased urine output, then we proceed for lab tests. Now, what are the lab tests? Number one, we need complete blood count, thyroid test, urea, creatinine, sodium, potassium to check renal causes, urine routine and urine ACR to check renal causes, LFT, liver function test to ascertain liver causes. We should do ECG, echocardiography, to understand whether heart failure is there or not. Sometimes fibroscan we do to check liver causes, upper GI endoscopy, Doppler splenoportal axis to find liver causes. So different lab tests help us in diagnosing the causes of edema. Now, treatment of edema totally depends on what is the cause of edema. Is it liver cause? Is it lung cause? Is it heart cause? Is it hypothyroid? Is it drugs? So, what is the cause? But however, certain basic things we must remember in generalize this edema. One is we must do salt restriction. Number two, we must do fluid restriction. Number three, there are certain drugs. Now, in case of heart failure, there are 4 pillars of treatment, but we should remember that both in heart failure, renal failure, etc., diuretic is one of the main pillars of therapy. What are diuretics? Diuretics are drugs that remove excess water from the body. Now, diuretics are of several types, and these are classified according to the site of action in the kidney. Diuretics actually are life-saving drugs. It not only reduces edema and decreases BP, but they alter the natural history of the disease. That means they save life and change the course of the disease. So these are really life-saving drugs. There are several varieties of diuretics. Number one, thiazide diuretic, thiazide-like diuretic like chlorthalidone, indapamide, metolazone, etc. Then there are loop diuretics. Then there are mineralocorticoid receptor antagonists. These are used very frequently in society. We almost use it regularly in our daily practice. Now, thiazide or thiazide-like diuretics are mostly used in treatment of hypertension and also in heart failure. Loop diuretics like furosemide and torsemide are slightly more potent, and they are perhaps more useful in presence of kidney disease and heart failure. There are other drugs like mineralocorticoid receptor antagonists like spironolactone and eplerenone, which are used in resistant hypertension and heart failure. They are frequently used. Now, diuretics are life-saving drugs, but however, we should remember something, that they are not free of side effects. The commonest side effect is dyselectrolytemia. Almost all the diuretics may cause low sodium, that is hyponatremia. Most of the diuretics like thiazide and loop diuretics may cause hypokalemia, that is low potassium. Some diuretics like mineralocorticoid receptor antagonists like spironolactone, eplerenone may cause hyperkalemia, that is increased potassium, and these increased potassium may be significant in real life when this mineralocorticoid receptor antagonist is used in combination with other life-saving drugs like ARBs, like telmisartan, olmesartan, etc. These combinations may cause severe hyperkalemia, raised potassium. So whenever we are using diuretic, it is definitely a life-saving drug, but we must know what electrolyte disturbance it may cause and what is the optimum dose. We will not use very high dose. We have to know the optimal dose, and we must know the drug interaction with other life-saving drugs. Only by knowing the side effects and interaction with other drugs and closely follow-up of these patients, we can save life of these patients. Thank you.